Now we're going to talk about cohort studies. And cohorts are almost like the reverse of case control studies.
Okay.
A cohort is basically a group of people who share particular characteristics within a particular period of time. So you could have basically a group of people born in the same year, people who attended the same class, people who were, developed a diagnosis in a particular time period, people starting a treatment at a particular period of time. And then you take this cohort, and if you follow this cohort through time, through a particular time period, then what you're doing is a cohort study. So what you're doing in a cohort, so remember in a case control study, we looked at people with an outcome, people without an outcome, and we looked at the exposure. Here we're doing the opposite. We're comparing a group that is exposed to something, a group that is not exposed to something, and we look in time, we follow them through time, and we see whether they develop a particular outcome. Yeah. So if we took a bladder tumor example, you take farmers exposed to pesticides and people who are not exposed to pesticides, and then you follow them for 20 or 30 years, and you see how many develop transitional cell carcinoma. Okay, as an example. So what you're measuring here, you're starting with the exposure, and you're measuring the occurrence of disease or the outcome of interest through time. And
No intervention.
this is still no intervention. This is an observational design. You're just looking at what happens to people. You're not doing anything to people. The only intervention studies are basically, or should be
kind of an
randomized.
intervention, because if you think something influences,
It's not an intervention.
if you think hairspray may damage, and you don't tell women,
That's an ethical issue.
Oh, that's an ethical issue.
so it's a kind of, you don't decide not telling them,
But remember what we said in the first lecture
it's a definition.
about equipoise. You shouldn't start a study if you already know the answer.
Right.
If you don't know the answer, you're not telling women to
That's the
use or
problem
not
they
use
have
hairspray.
with, how else is called in English, hyperbaric oxygen and CO. Nobody knows if it helps, but there's no physician that we not in, it helps if you have high CO levels acutely. But if you arrive to the hospital after you got oxygen and the levels are fine, they give now hyperbaric oxygen because they believe some of the CO is in their brain.
So you mean sometimes there are
The
accepted clinical
indications
treatments
today,
but actually no
the
evidence.
indication today for hyperbaric oxygen is a certain level of CO
Mhm.
when people arrive to the hospital.
זה טיפול,
זה הטיפול.
intervention, זה מחקר אחר.
No, but it's not, because you're not, what she's saying here is sometimes you don't necessarily, you don't actually have good evidence.
Right.
But
So
no
some
one is
people
willing
give,
to.
some people don't give, and then they try to compare them because
Yeah.
nobody knows if there's benefit of hyperbaric oxygens with normal levels of CO when arriving.
Yeah, so this is more kind of, but it
So
depends,
some
yeah.
people recommend, some people don't recommend, and you cannot really do.
No, but you can have what's called natural experiments. So for example, if one hospital
Gives.
gives and another hospital doesn't have a machine, or the machine is broken or something, then you can compare, then you can generate evidence. But here you don't touch the patient, you don't do anything to them. Same with the hairspray, you don't do anything to them. You just look at what they're exposed and what they're not exposed, and then you look at the outcome. The important thing here is that everyone at the beginning should not have the disease, should not have the outcome of interest. So everyone starts healthy from the perspective of the outcome. They're divided into exposed and not exposed, and then you look at whether or not they develop the disease. Sorry?
So the point is how you divide them.
So you need to define your exposure very
You define
carefully.
your exposure, if the exposure is hairspray, so you defined.
So So if I have 1,000 people who fly, as my colleague just said, on an aeroplane,
Yeah.
and I measure corona outcome, it's not a cohort study.
I'm sorry, I didn't understand the example.
1,000 אנשים במטוס,
Yeah.
ו1,000 יורדים,
Yes.
ואז אני מודד קורונה, positive, negative.
Well, if you
This is
expose
not cohort,
it,
because
it could, well, it could be, you know, if your exposure is
The
using
exposure is
air
the flight,
travel,
is
so
staying
you have
right.
1,000 who use air travel and 1,000 who don't, and then 2 weeks later you look at whether they develop corona. Yeah, you could say that's a cohort study,
this is okay.
because not an intervention doesn't mean that nothing happens to them. It means you as a researcher, you don't do anything to them. If you said, okay, I'm going to take 2,000 people and I'm going to randomize you, and these 1,000 people, I'm going to pay for you to go on holidays in Greece. Okay, that is an intervention because you are assigning. That sounds really nice. I think it'd be hard to get funded. But you know what I mean.
אולי יש לי 1,000.
אולי הוא נחשף באיירפורט, לא במטוס. אולי הוא נחשף בבית, אולי הוא נחשף בדרך.
Yeah, so then there are also confounding factors. There are also things that, so just because you do that, it doesn't mean, even if you find an association, doesn't mean that the air travel, you know, because if the 1,000 people who didn't fly, like you said, live in a city where the incidence of corona is, you know, 10 times the national average, you're going to have confounding. You need to, so you need to adjust for that. But the point with intervention and non-intervention is not what happens to people, is whether you give the exposure to people. If you're doing a trial or an intervention, you know, running therapy, you choose the people who are going to go and run. It's not like they're running and you're seeing what happens to them. It's a subtle difference, but it makes a big difference. It's really important that at the beginning of the study, you make sure that the people do not have the outcome of interest. So with oncology, it could be a challenge, because you may have some patients who are, you know, in preclinical stage or pre-malignant stages of particular outcome. You might need to check for that. But when you put your cohort together, you should try and screen out patients who already have the outcome. So this is your inclusion and exclusion criteria. And then once you've done that, you have your group, and then you measure the exposure in everyone, and you divide people into exposed and not exposed. And you need to think again about exactly what the exposure is. You know, flying, you know, is like flying 30 minutes to Cyprus and flying 12 hours to New York. Is it the same thing? Is, you know, one flight in a year versus 10 flights? I mean, it needs to be, again, comes back to this idea in the first lecture of case definitions. You need to be as specific as you can, and have, you know, if person fulfills criteria X, Y, and Z, they are exposed. If they don't, they are not exposed. And you need to stick to that. Oh, yeah. And one of the strong things with one of the advantages of a cohort study compared to a case control study is that here, because you start with the exposure, you know that the exposure happened before the outcome, right? So you knew that they flew before they developed corona. If you do a case control study, because they both happened in the past, maybe the patients are a little bit confused, and maybe they're talking about a flight that happened after they developed corona, which messes up your relationship. Here, the temporality is much clearer.
Right.
Okay. And then, so you have your group of patients, you divide them between exposed and not exposed, and then you follow them over time to observe the development of the outcome that you're interested in.
And that's the difficulty, because some of them can quit.
We'll come to that. It's
Some
difficult.
of them can start using,
It's
if they're in
expensive.
the control, they might start using hairspray, or like you have to really, really follow them.
So
You
that's
have to
called
really know what happens.
measuring person time at risk, and we'll come to that in a minute. That means that some cohort studies are extremely long and extremely expensive. Take, for example, the Framingham studies on cardiovascular diseases, right? This is a study that took 30 years, 40 years. It means that the people who started the project may be dead by the time the final papers come out. Same with the GP cohort study started in the 40s and ended up in the 70s or 80s to show that unequivocally smoking was associated with lung cancer. And this is particularly true, in oncology is very relevant when the outcome is very far in the future. If you're exposed today to pesticides, to smoke, you're not going to develop cancer tomorrow. It's not like infectious disease. It could be 20, 30 years into the future.
Side effects of immunization.
Could be.
We know that the corona immunization, we don't have side effects after 2 years.
Exactly, but
Nobody knows what happens in 10 years.
Absolutely. So
Right.
you need studies to do this, and this is a major something that is difficult. But these studies do take place, and there's tricks. When we'll come to it in a minute. So you're asking the difference between you're saying, is it an intervention? Is it not an intervention? A randomized controlled trial and a cohort have the same fundamental
Sometimes they
data.
write double blind, randomized cohort study.
Yeah, you can make sure that the people who do the study don't actually know who is exposed and who's not, so you don't actually bias the study. But randomized, no, you can't randomize a cohort study.
You can't.
You can blind, you cannot randomize, because randomize means you randomize to your exposure, to your intervention.
Okay.
If you do that, it means you're doing something to people.
So that's not a cohort.
That is not a cohort, that is an intervention study. But if you look at this graph, and you'll see that in a cohort study, you have your population, you divide them between exposed and unexposed. You don't do anything to them, you just look at their exposure, and then you look at the outcome. And you talked about loss to follow-up, we'll talk about that. In a cohort study, there's an extra step, which is you randomize and you choose who gets the exposure and who doesn't. Yes. You randomize into intervention and control. But other than that, the principle is similar. So we talked about the Framingham study. This is for those of you who did medicine, you'll be familiar with that. This is the study that tells us that blood pressure, age, etc., are risk factors for cardiovascular disease. And the reason they did this, the reason we know this, is because researchers went into a small town in America called Framingham, and they followed people for 30 years to look at. They measured all these things regularly: blood pressure, age. I can't remember what. There were a few other factors they measured. And look, it started in 1948, and in 1971 they were still recruiting patients. It's crazy, but it's the only way to really at a very high level, with a very high level of confidence, establish these associations. There are others like this. There's the nurses study. There's the British general practitioner studies. And again, the issue of choosing your controls is choosing your unexposed is a challenge, because again, the ideal comparison group should be exactly the same as the exposed, except that they're not exposed, right? So if you're doing a study on exposure to pesticides and you're interested in the risk of bladder cancer, you need to, your two groups should be the same age, the same socioeconomic status, live in the same area, should be the same in terms of smoking exposure and other things, except for this particular exposure that you're interested in, and then you look at the outcome. In real life, it's not possible to have exactly the same groups, but what you do is you measure all the different other exposures, smoking, age, etc., and then you can adjust for it in the analysis. You use models that tell you, after you take these other things that are different into account, this is the result. And this is where you see regression models being used in studies, because it enables you to take these other factors in consideration, to only focus on the association between the exposure and the outcome after having adjusted for all other factors. So here you are interested in disulfide exposure and the incidence of heart disease. So, and disulfide, I mean, I don't actually know much about it, but it's a chemical that you get if you work in a particular type of factory. So your controls should be other factory workers, right? Same socioeconomic level, in the same geographical area, but who are not in, whose work doesn't expose them to that particular chemical. That will limit your chance of bias and of confounding.
Even though it's not the same people.
Of course,
It's
it's
the same group of people.
well, it may be another factory in the same town, for example. It's not the same group, it's the same it's the same source population.
But, okay.
What-
The fact that.
What you shouldn't do is take,
In
yeah.
your example, the fact that it's different factory makes it different people.
Of course it's different, they expose and the unexposed are different people, in most
In-
cases.
In contrast with the Framingham study, it's the same people.
Well, it's the same people, but they're still divided into, so
But
you can think about it
It's
differently.
divided.
Imagine a town, this is in the
Yeah.
this is in the US. Imagine a small town in America which has 2 factories. Okay, so your population is factory workers in this town. One work in this particular factory exposed to disulfide, and the other one in the other factory that is not exposed. Yeah, what you shouldn't do is take factories workers from a factory in a town in America, and the unexposed are factory workers in China. Okay, because there are many other things. You know, the diet will be different, etc. So they should be as comparable as possible. But remember, this is real life. This is observational studies. All you can do is observe what is happening. So it's never going to be perfect, but you need to choose. You need to think about this when you choose to minimize the differences.
And then you can do animal studies, and then you can do cohort. Like you can start with these kind of studies,
This is like the divers in the Kishon.
right?
Yes,
So that's what it was. That's the reason it wasn't proved.
because you couldn't have a comparison.
Because I don't know the exact statistics.
So this is interesting. You know, the divers in the Kishon is an interesting example. Say, for example, you're a factory and you're accused of, you know, poisoning your. So what they will do is they will hire epidemiologists to look at the study, and they will say, well, you can't be sure because, you know, your controls are not exactly the same. I mean, you can always find reasons to, and this is why, you know, the strength of the evidence is limited. But, you know, if you find a much higher incidence of cancer in one group and not in the other group, what you have to think about is, are the differences apart from the exposure big enough to explain the difference that we're saying? And if the answer is no, then most likely the exposure that you're interested in, you know, the polluted water is a contributor. You know,
Always an issue with
the tobacco industry is very famous for that. They paid millions and millions of, well, not just lawyers, but epidemiologists to say, well, the studies that you did are not valid because X, Y, and Z.
That's what
Actually,
happened with
smoking
Mamat
is
Hoda.
healthy for you.
They
Yeah.
smashed the.
No, it's valid also for radiation.
Radiation, yeah.
The common story is, I live in Harazim Street in Tzfat. This is a cancer street.
Yeah.
Come and prove that it's
It's
wrong.
very hard to prove. It's very hard to prove generally. It's not necessary to, I mean, there's a lot of studies, you know, the studies of certain cancers with high, you know, power lines. Mostly clusters are very, because then it's a different kind of studies. You can see whether you detect more cancers than expected in a particular areas. And sometimes the answer is yes, and sometimes the answer is no. Also, people, you know, people have, just because there are 2 cases of lung cancer in your, or mobile phones, whatever the exposure is, just because there are 3 people with, you know, cancer in your street, doesn't mean that your street is a cancer street. This is something that, you know, a lot of these studies, for example, they will say, oh, there's a lot of cancer in our street, but actually when you look, there's one breast cancer, one lung cancer, and actually the mechanisms underlying the pathogenesis are very different. So that's why you need to look very carefully. Who are your cases? Who are your controls? What is the exposure, etc., etc. So, as we said, and you all raised this issue, because you don't randomize, you cannot guarantee that when you do a randomization, when you do randomized controlled trials, you know all the characteristics at the beginning, and then you assign them to one group or another. So you know that they're comparable. In a cohort study, you don't choose the exposure. People are exposed or unexposed. There's nothing you can do about it. If someone lives on a street with the power line and another one doesn't, you can't change that. That is, and if they're different, you have to adjust for the other differences. And this is why we check for potential confounders and we adjust for them in the analysis. Again, very similar to cohort studies, the data collection should be identical for all study groups. So the exposed and unexposed, you should recruit them in the same way. You should recruit the, you should measure it, and you should measure the outcome in the same way. Really, the only difference is the exposure. Now, in cohort studies, there are essentially different things that you can measure at the end. One way to do it is that you take your exposure and you take your outcome. So you take your exposed group and you take your unexposed group, and then you look at the end how many people develop the outcome, right? So you have, say, 100 people who smoke, 100 people who don't smoke, and in the end, 10% or 80% of the people who smoke have lung cancer, but only 5% who don't smoke. Okay, so you have your denominator is the number of people, and your numerator is the number of people who develop the outcome of interest in both groups. And this is called a risk. Yeah, or a risk or an incidence.
And the risk is measured in odds ratio.
No, the risk is measured in risk ratios. There's no odds there.
Okay.
So the risk is the likelihood of an outcome happening. So if you have 100 people and 5 develop the outcome of interest, the risk is 5%.
So you don't take into consideration what happened in the control, like in odds ratio.
Odds ratios are really only for case control studies. Here you're looking at the
So
risk.
you're saying if you don't smoke, your risk of having lung cancer is 5%. If you're smoking, your risk of having lung cancer is 8%.
Yes, and then you do the ratio. You do a risk ratio.
And then you do a risk ratio between
So you
them.
divide the risk
So
in
it's the
the
same technique, it's just named different.
well, yes and no. In the case control studies, you looked at the odds of exposure in the cases, odds of exposure in the controls, and you do the odds ratio of exposure. Here, you're doing the risk of outcome in the exposed, the risk of outcome in the unexposed, and what you're calculating is the risk ratio of the outcome. Yeah. So if, say, for example, 20% of smokers have lung cancer, and 2% of non-smokers have lung cancer, the risk ratio is 10.
So it's exactly the same technique as before, it's just called different. The meaning is
the same. The approach is the same, that you divide the risk in the case but in cohort studies is the risk in the
because in
exposed.
cohort you look at the exposure,
Exactly.
and here you look at the outcome.
Exactly.
But the definition, the meaning is different, but the technique is the same.
Correct. Yeah, exactly. However, there's a slight issue with this. And this is that when you do this, when you do risk ratios, you assume that the entire population has been followed the whole time, and that the risk, that the exposure remains constant over time. So if you're looking at people, say again, smoking and lung cancer is a very good example. You follow people for 20 years. Some people may be smokers at the beginning and then stop smoking. Some people may start as non-smokers and start smoking. Some people may smoke 2 cigarettes a day and then go to 20. Some people may cut from 2 packets a day to 1 cigarette a day. So the exposure is actually not constant over time. And also some people die, some people move. There's another way to measure the outcome in cohort studies that take this in consideration. And this is using rates rather than risk. Now, this is getting a bit technical, but it's important when you see a paper because the incidence rate and the incidence risk is not the same thing. Now, I'm going to try and explain this to you. So rates are much more difficult to measure, but they are more accurate and a more accurate way of measuring the occurrence of an outcome over time. And it takes in consideration that people are at risk for different lengths of time. So let me try and explain this to you. Say there are these 7 people at the beginning of the year, okay? And you want to know how many of them develop influenza in this year, okay? Now, imagine that you can only get influenza once. Okay, imagine you cannot get reinfected, at least not in the same year, right? So let's look at the first person here. The person at the top, she starts, everyone is healthy at the beginning, right? And she goes through the year, January, February, March, blah, 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 blah. In September, she becomes infected, okay? After September, she's no longer at risk because she already developed the outcome. So the time after this shouldn't go in your denominator because this is no longer a time where she can become sick because she's already been sick and you cannot be sick twice, okay? The second person, the same thing. Imagine she becomes sick in February. Well, all the time after February, it doesn't count in the denominator because this is not a time that she contributes where she could become a case. She's already become a case. Imagine this person, the fifth one, she starts the year. She's not sick. She's fine, but she dies in September of something else, right? Well,
this was surprising.
this just means that she's no longer in the study. When you're dead, you cannot.
She went to the Caribbean.
Yeah. No, this is the next one. Okay, she can no longer. She's not in the population anymore. So the time between September and December doesn't count.
Okay.
This person, imagine this person. They actually move. No, imagine this one. He only moved to your area of your study in July. So actually, you don't know what happened. You didn't actually measure his risk in this time. So really, the time only starts contributing there. So you can actually measure if you do a cohort study.
So the question of your research is, what's the chance of a person getting influenza within a year?
The question of my research here is, what is the incidence of influenza? So the incidence is the number of new cases
In a year.
in a year in a population.
So why, I understand why if someone wasn't here at the beginning or at the end, it changes anything. But if you ask what the chance of a person to get influenza the next year, then the other ones do get them within the same year.
So here we're only looking at one. Imagine there's no time before and no time after. We're just looking at one year here. What you can do if you're calculating the risk of disease, the risk or the incidence is the same thing. The number of new cases here
It's 5 out of 7.
is 5 out of 7, right? Correct.
This is a risk.
This is the risk of influenza.
Risk
This is
rate.
a
So it's a risk. No, it's a risk. It's the proportion. The proportion is the number of people who develop the outcome divided by the number of people.
Okay.
Yeah. The rate actually takes in account what we call person time at risk. So here, this person contributed 8 months where she's at risk of the disease and then developed the disease. This one, only 1 month. This one, 4 months. This one, the entire time. This one, 8 months. Okay. And then when you're calculating a rate, your denominator, the bottom, is no longer the number of people, but it's the total time at risk.
I understand the technicality, I understand what you're doing.
Yeah.
I understand mathematics, which is not complicated. What I don't understand is the meaning of it. The meaning of the previous calculation, I understand. I have a year, how many people will get influenza this year? If I am in healthcare system, I want to know what should I.
The meaning is that it's a more precise
What's the question? What's the question?
The question is the same, and it answers the same way, like the risk and the rate answers the same question, but the rate gives you a better, more precise answer because you're measuring the denominator more precisely. Okay? So
לא, אני
So-
מבינה את המילים.
I understand what you mean. It's not an easy.
לא, אני צריכה לראות מחקר שבדקו את זה ואת זה ולהבין מה המשמעות. אני לא מצליחה להבין את המשמעות.
In practice, yeah.
אם אני שואלת את עצמי, אם אני היום
Let me try and give you an example.
מנכ"ל משרד הבריאות, אני רוצה להעריך עכשיו מבחינת רופאים, אחיות, אני רוצה לדעת כמה אנשים...
Let me try and give you a real example. Maybe you will understand. Imagine you want to know. Imagine you want to know the incidence of COVID-19 in Tzfat. Okay, so you're doing a study now in 2021. So you go on Google and you look, what is the population of Tzfat? I don't know, 36,921. And how many cases there were in Tzfat? 1,600. So the incidence of COVID in Tzfat is 1,635 divided by 36,000, whatever.
Some of them were not living here.
Exactly.
They were
Some people
vacationing
moved
in
out.
Jerusalem.
Some people were out of the thing. Some people moved in mid-year. Some
So
people.
that's not a real chance.
Exactly.
Okay,
So
now I get it.
The reality, it will probably be quite close. But this is
No, it could be not that close.
it depends how stable the
Because
population is. So if you're doing it in a small moshav where no one moves in, no one moves out, it's probably not very important. If you're doing it in a refugee camp where there's thousands of people coming in and thousands of people coming out, then the difference is huge. And maybe so you have to think, but this is much more
So
difficult.
it depends what you want to know, because if you're interested in, okay, how many facilities do I have to build or have to do, maybe the first question answers it, because what matters to you is the absolute numbers. But if you want to know the chance of a person to get sick the next year, the individual, then this is much more accurate.
Absolutely.
Am I right?
You're right.
Okay.
But this is also much more complicated.
It's much more
much more
complicated, but it
expensive.
gives you a much clearer definition or estimation for the single, for the
Exactly.
individual. The
Absolutely.
other one gives you the absolute numbers. Maybe I want to know how many nurses should I put in the clinic, and I don't care if for that person the risk is higher or lower, but for the population, I want to have 3 nurses in a shift.
But this is also about population. This is not about individuals. This is about the burden of disease in a particular population, but it measures it in a much more precise way. Because if you're in a place where a lot of people move in and out, for example, if you just do an incidence risk, the answer is going to be very inaccurate.
It's going to be higher.
Well, it depends. It could be higher, it could be lower. It depends. But it doesn't mean that you have to do this every time you do a cohort study. But it's worth thinking. It's just important for you to know, because also when you read papers, the other thing to say is, especially non-epidemiologists, but also epidemiologists, are actually really, really bad at using this terminology. So if you see risk and rate in a paper, you have to look at what they did to look at whether they actually did what they say they did. When people talk about mortality rates, most of the time it's actually a risk.
That's what they talked about all the time with Corona. That's the discussions.
Mortality rate is most of the time risk, only risk.
Mostly, because people take a population and how many people died out of the population. So what I want you to know is that there's that risk and rate are 2 different things. And when you read a paper, when you see the rate of complication, for example, in surgery, you have to really look, is it really a rate? Is this actually what they mean? So the incidence is the number of, and the incidence rate is the number of outcomes that you're interested, divided by the total person times risk. The incidence risk is the number of new outcomes divided by your population. So this was a study that looked at the risk of coronary heart disease with exposure to hormone replacement therapy, right? So they followed a lot of, obesity and coronary heart disease. So they followed, and also people, if they measured It's a lot of patients,
You
a
have
lot
a
of,
total of 100 with the disease and two.
no, you have 85 cases.
The total of sick women is 126.
126 out of 276,000 women years of follow-up.
Ah, okay.
Yeah.
Years of follow-up.
So if you take 1,000 women
I thought it's
and
okay.
you follow them for, or say you take 250,000 women and you follow them for a year, that's 250,000
And out of
women
them,
years.
126.
Correct.
they have the disease.
So there you would get a rate.
Okay.
Okay, now to make things even more complicated, what we talked about so far is prospective cohort studies. You start now with the exposure and you follow them through time. But you can actually also do what's called retrospective cohort studies, meaning that both the exposure and the outcome already happened in the past. But you analyze it in the same way. You start with the exposed and the unexposed, and you look at the outcome. The only difference is the outcome already happened.
What's the difference between retrospective cohort and
Case control.
no, the first one we took?
Case control. The difference is that you analyze it differently. In a retrospective cohort, your two groups are the exposed and the unexposed, and then you look at the outcome. In the case control study, the two groups are the cases and the controls, and you look at their exposure.
Okay, so I'm in a retrospective cohort study. I'm beginning to sound professional. In a retrospective cohort study, you're looking, let's say, in files, children who had influenza last year, and children who had influenza who didn't have influenza last year, and how are the coronary function to
Exactly.
So you're looking in your files.
Correct.
You're looking first for the
exposure,
and then you
Yes.
ask yourself what's the outcome.
Yes.
As opposed to what we did before, I'm
Yes.
taking all the kids with coronary disease and I'm asking who had influenza
Yeah.
last year.
And the main reason how you choose to do one or the other depends on whether your exposure is rare or common and whether your outcome is rare or common. So if the exposure is rare, you go for a cohort. If the outcome is rare, you go for case control. But also you can do a cohort study on a closed population. You can do a case control study if your definition is not well defined and you're looking for cases there and there, then you need to do a case control study. You can't do a cohort study. So prospective cohort study, your investigator, you're here at the beginning, and then you're going to follow up your patients over time. You might die or change jobs before the study is finished, if it's a very long study. In a retrospective cohort study, the study starts here. The disease already happened and the exposure already happened, but you look at it through time. Let's give this another great advantage of cohort studies is that you can examine multiple diseases for one exposure. So say you have a rare exposure to a particular chemical, you can look at the association between this chemical and brain cancer, lung cancer, bladder cancer, all of them, right? Whereas with a case control study, you can't do this. But with a case control study, you can look at multiple exposures. So if you have a particular cancer, you could look at exposure to many different things. So you could look at multiple exposures. In a cohort study, you can look at multiple outcomes. As we said, it's good for rare exposures. If you identify the population by choosing exposure to something rare. So for example, a chemical. Say you want to look at
the children of Remedia.
Sorry.
The children of Remedia, the children that were sick. And then they said maybe all of them. That's
the other way around. That's
the other one.
Yeah.
That's case.
So cohort is for rare exposures. It's really good. Cohort studies, if you're doing specifically prospective cohort studies, are long and expensive and labor expensive. And exactly as you all said, it's Mohammed, you pointed it out many times. There are many, because you don't choose who gets the exposure and who doesn't, there are many other determinants, many other characteristics that individuals have, and that introduces confounding. So you need to record those, and you need to to adjust for them. For example, in a nurse study that we mentioned looking at, or before it was obesity and cardiovascular disease, here it's HRT and cardiovascular disease. The women who take HRT and women who don't are probably quite different. You know, their age is different, their socioeconomic status is different. So if you don't adjust for that, you're not just measuring the effect of HRT, but you're measuring
Right.
the effect of HRT together with all the other factors. If you know these other factors, you can adjust for them in the analysis and isolate the effect of the exposure that you're interested in. Yeah? Then you have the issue of loss to follow-up. You know, if particularly when the outcome is severe, you know, if people become very sick, then it's less likely that they continue to participate. You know, if you're asking people to fill a questionnaire every few months, for example, to ask them about if they're sick or not, if they become so sick that they just don't feel like doing it anymore, then you're going to have more exposed people follow loss to follow-up than unexposed. This is a major source of bias in cohort studies. Right? That's it. So this is cohort studies in a nutshell.
לא, לא.